Okay, for our next section, which is going to be on functional bowel disease or disorders of the brain-gut axis, our first speaker made her way here from a meeting in New Mexico yesterday, had to get past Air Force One and Air Force Two, but fortunately she's here. She's a clinical professor of medicine at Stanford and vice chief for operations in the GI division there. So Linda Nguyen, thank you very much for coming.
Thank you for inviting me back. This place actually brings back great memories because the last time I was here was prom, high school prom. So happy to be back here. Let me see. How am I moving forward here? Okay, so these are my disclosures. And what I thought I would do with the topic today was take DDW from the bedside, to take sort of the abstracts from DDW to the bedside in functional dyspepsia. And I'll go over a little bit why I chose to focus on functional dyspepsia. I'm going to start by reviewing the current knowledge and therapies in FD, and then discuss abstracts that has potential to change the diagnosis and therapies now. So just as an overview, looking at the Rome 4 functional upper GI disorders, you have a list here of the functional esophageal disorders and the gastroduodenal disorders. Rather than going through kind of a hodgepodge of abstracts related to all of these DGBIs, I thought to focus on functional dyspepsia. And the reason for that is that this is one of the most common diagnoses we will see outside of constipation. And this is a worldwide prevalence of DGBI survey from the Rome Foundation. And what they did was they had internet surveys as well as household surveys. Number one, if you're not familiar with DGBIs, please make sure you are, because of the internet surveys, over 40% of individuals met criteria for one of the DGBIs. When you looked at the household surveys, the functional dyspepsia was number 2 to functional constipation. So you will see functional dyspepsia, which is the reason why I chose to focus on FD today. So this is the AGA, this is the American Gastroenterology and Canadian GI Society guidelines on the approach to dyspeptic symptoms here. And I'm calling your attention to a few things because the abstracts that I will be discussing will focus on that. So in someone with dyspepsia without alarm symptoms, the recommendation is to test for H. pylori and treat if necessary, if positive. For those who are less than 60, it's not recommended to do endoscopy. So this is an abstract where this is from Canada. And in Canada, they have a primary care pathway for FD, which basically takes, oops, how do I go back? Takes this guideline into a pathway where, primary care doctors can go from step 1 to 2 and really to decrease utilization of endoscopy. But despite these guidelines, what this group did was they retrospectively looked at outpatient upper endoscopies and tried to categorize patients into this low risk dyspepsia. So those without alarm symptoms and under the age of 65. And of the 1,200 plus endoscopies, 372 were for dyspepsia. And then of those, about 35% were low risk in terms of having dyspepsia without any of the alarm features. And so what they found, it wasn't their primary endpoint, but only 20% of their patients underwent or had implementation of this primary care pathway, and almost 80% of the patients who underwent endoscopy did not have any of the alarm features. So what were the endoscopic findings? So only 9 of the 130 low yield endoscopies revealed anything that was actionable. And there was only one gastric ulcer, and the rest were things like Candida esophagitis, EOE. When present, these abnormal findings are found in those over the age of 50. And then when they followed these patients for the following year, they did not see any changes in diagnosis or increase in healthcare utilization. So based on these findings, so some of the takeaways that you'll see are kind of my thoughts and my implementation of these abstracts. So one, rethink endoscopy in your low-risk patients with dyspepsia, but also potentially lowering the age cutoff to 50, especially in patients who are H. pylori negative and are not responding to therapies. And we're all dealing with limited access in our clinics, in our endoscopy units. So one of the things that we're looking at now is, can we do similar things as the Canadians in optimizing a guideline and a primary care pathway so that we're not doing unnecessary upper endoscopies? Mark mentioned earlier about eosinophils and mast cells in functional dyspepsia, and this is the same abstract. But I'm going to go into a little bit more detail because it dovetails into the second abstract I'm going to talk about. So this is a meta-analysis of patients with functional dyspepsia and controls. And in addition to the eosinophils that Mark mentioned earlier, they also looked at mast cells. And essentially what they found was that patients with FD had greater eosinophils and mast cells in the duodenum than those without FD. And again, what they're seeing is this kind of microscopic duodenal inflammation in FD that, in addition to the numbers of eosinophils and mast cells, they saw greater degranulation of the eosinophils. And then when they grouped the eosinophils in the post-infectious functional dyspepsia versus the non-infectious FD versus controls, there's a gradient in the degree of eosinophilia. So the post-infectious kind of immune dysregulation may be playing a role there. So, in terms of kind of ongoing evidence that we're seeing duodenal eosinophils and mast cell counts in patients with FD, also things we're seeing in irritable bowel syndrome, could we be looking at antihistamines and mast cell stabilizers in treating patients with functional dyspepsia, especially those who do not respond to initial therapies? And one of the things I did not show is that the mucosal, in terms of the immune cells and the FD subtypes, unfortunately, other than the post-infectious FD, there's no way to categorize or to predict the histology based on symptoms. So this is a general approach that a lot of us take, and this is adapted from the Japanese group in terms of what do you do, or what's your approach to patients with the intractable functional dyspepsia? So you've treated them with proton, you've eradicated H. pylori, you've done proton pump inhibitors. What do you do next? And I'm going to focus here on the gastric function testing, which Prakash and Mark had talked about earlier. This is a study that came out from multi-center. This is based on an old study, the MA501, which was a Medtronic study where patients underwent a combined gastric emptying scintigraphy, so the 4-hour gastric emptying scintigraphy, plus the wireless capsule motility. And then based on those results, the PIs prescribed a therapy. And there were no a priori distinctions. It's just whatever you wanted to choose based on the gastric emptying results. And then they had follow-up symptoms at 6 months. And so it was a total of 147 patients. And what they found in looking at the concordance between the gastric emptying scintigraphy and the wireless capsule motility, the gastric emptying test, there was only there was discordance in about 24% of patients. And you see here that majority of the time, 58%, these are patients who were enrolled in the study because we all thought they had gastroparesis based on their symptoms. 58% had normal both. So so that's the comment of, don't order the test unless you think the symptoms are there or you know what you're going to do with it. But this test, interesting. So when they compared the two discordant groups, so the abnormal gastric emptying scintigraphy only or the abnormal wireless capsule motility only, they looked at different features and found that the ones with abnormal wireless capsule motility only tended to be younger, had lower BMI, and less likely to have diabetes than those with the scintigraphy abnormality alone. And this is the interesting part here, taking those two groups and comparing their response to different therapies. So both groups responded to prokinetic agents, mostly erythromycin, metoclopramide, domperidone, and protastigmine were the four most common ones used there in terms of the prokinetic. The ones with the abnormal wireless capsule motility only actually were worse with the antiemetics compared to those with the abnormal gastric emptying scintigraphy. It was opposite for neuromodulators. So the WCM abnormal patients responded. So a negative score is good. So they had a decrease in their symptom scores, but those with an abnormal scintigraphy, their abdominal pain scores got worse. And again, there's kind of some suggestion that this is likely due to different mechanisms in terms of the pathophysiology of the gastric emptying abnormality. So my takeaway here is that patients with upper GI symptoms, 18% of those who have normal gastric emptying will have an abnormal wireless capsule motility. So especially if they're younger and female, you may want to look at a wireless capsule motility test if you are continuing to be concerned about delayed gastric emptying. And there are differential responses so that, when irrespective of whether you have a scintigraphy or a wireless capsule motility result, it may change the first line therapy that you choose. This was a study, and I don't understand all of the modeling that was used. So I'll tell you that right now up front. The question here is, whether or not, doing wireless capsule motility or gastric emptying scintigraphy early can help to decrease long-term costs. And again, this was based on that MA501 study, and they use only the wireless capsule motility study with sort of major assumptions that looking at responders versus non-responders to therapy, that they found that based on this modeling, that that with the wireless capsule motility testing, there may be a cost saving. So yes, wireless capsule motility may reduce healthcare utilization if you have in terms of having intervenable results. As someone who was a part of the study team here, but not part of the study, there were more patients with constipation than there were delayed gastric emptying, so delayed colonic transit, and that may have been what affected the outcome measures. So that's sort of my take on this, and I agree with Mark's earlier comment that look for other things like constipation, because we have a lot more therapies for constipation than we do have gastroparesis. So I'm going to talk about some novel therapies that I think may be emerging for functional dyspepsia. So this is an algorithm, again, from the AGA in terms of the treatment approach to functional dyspepsia, and based on whether it's epigastric pain syndrome, postprandial distress, or an overlap. This is sort of the order that I typically use for patients. I move it around a little bit based on other comorbidities, et cetera. This study came out from the Leuven group, which I thought was quite novel. It's a small study, and they looked at the most allergenic foods. So similar to the EOE, they took the 6-food elimination diet, and they took patients with postprandial distress subtype and functional dyspepsia. And they measured the Leuven PDS scale, which is a symptom severity scale before and after the 6-food elimination diet. They also then performed confocal endoscopic microscopy after 8 weeks of the 6-food elimination diet. And then they kind of infused one of these foods to see what would happen. Now they would stop if there was a reaction. So, so for example, if somebody reacted to nuts, they would not be challenged with eggs for the next one. They also did transepithelial electrical resistance on the duodenal biopsies on a small subset of patients. And so what you found here that was interesting is the 6-food elimination diet decreased postprandial symptoms in 75% of patients at 8 weeks. And then in half of their patients where they did the confocal endoscopic microscopy, they found that there was this abnormal extravasation of fluorescein. So they were reacting to the foods. And the most common food you see that they reacted to was egg white and wheat, and then kind of soy and milk. So those were the 4 foods most that they saw the reactions in. So in our patients with postprandial distress, especially if they have an atopic history, a 6-food elimination diet may be something to consider and discuss with patients. Now, keep in mind, they only looked at patients with PDS, so not the EPS patients and not the overlap. I'm not going to go over this study because Mark went over this in terms of, potential novel therapies for auricular vagus nerve or treatment of functional dyspepsia. And this is really a novel non-invasive therapy. I think what we need to figure out is what's the appropriate stimulation parameter? Is it 10 hertz, 25, 80, 40, et cetera, and for how long? So this study looked at 30 other studies. For example, for gastroparesis, there were 2 studies that have been published for cervical vagus nerve stimulation, and those studies did 4 minutes, 2 to 3 times per day. So we need to know what the stimulation parameters were. What I found interesting here, which Mark didn't show, was that they did the stimulation for 4 weeks. You do see a drop off in the symptom improvement, but it remains durable compared to the control group or the sham group, even at 12 weeks after discontinuing the therapy. In my patients who I have recommended auricular vagus nerve stimulation to, they do have kind of a rebound effect. So this was really the first sham study in FD that did show effectiveness between FD versus sham. So I think as the devices become available, this could be an option for our patients that is non-pharmacologic. And keeping in mind that we have 0 FDA-approved therapies for functional dyspepsia right now. So everything that you've been using is off-label, including PPIs for functional dyspepsia. In addition to the FD symptoms, there was also an improvement in depression and anxiety. And this has been seen in the psychiatry literature for years now, because they've been using auricular vagus nerve stimulation or even implantable vagus nerve stimulation for severe depression for years now. So here's some of the post-DDW practice changes that I'm making. One, this is putting on my operations hat that I will be working with our PCPs to implement a primary care pathway to improve access and reduce unnecessary endoscopies. Thinking about earlier EGDs, especially in patients who are PPI refractory, especially looking for eosinophilic esophagitis, gastritis, which were the most common diagnoses that were found. And if I am going to order a gastric emptying test in a patient, that my younger patients with lower BMI, I may order the wireless capsule motility, while my older patients with diabetes, I'll order the scintigraphy. And this is sort of a consideration. I think for me, because of my practice, I do order motility testing earlier, but that's because of the biased population that I see. I think we will have to look to see if earlier testing will reduce long-term costs. And like I said, I think my suspicion is that we're going to be diagnosing lower GI dysmotilities more so, and implementing that. And you ask me, well, can't you just get those symptoms like patients constipated? And I can tell you that how often my patients deny symptoms of constipation, no matter how many different ways I ask them, and they have markedly delayed colonic transit. So they're just like with reflux, there is poor correlation between symptom and the objective testing. And especially in my patients with atopic disorders, potentially discussing mucosal immune dysfunction in FDE. And again, because we're already using all off-label therapies using, antihistamines, H1 and H2 blockers or mast cell stabilizers, and potentially the 6-food elimination diet in patients with postprandial distress. And then, I've always been a fan of vagus nerve stimulation, and I think that the Intera, or the gastric electrical implantable stimulator, is a vagal nerve stimulator. But this whole concept of non-invasive vagus nerve stimulation is something that is near and dear to my heart. And seeing these abstracts at DDW just kind of reinvigorated the passion I have for this, because I do think that this may be a potential therapy for gastric disorders. And that's